In video 2, we talked about non-invasive bladder cancer and the treatments used. Sadly, some cancers do develop into muscle invasive bladder cancer. So today we're going to talk about some of the treatment options and the recovery programme with some patients and some clinicians. So I'd like if we can just go around and introduce everybody here. So John, if we can start with you, please.
So my name is John Ayling. I'm a consultant urological surgeon at Southmead Hospital, Bristol, and I specialise in the surgical treatment of bladder cancer.
Hi, I'm Amar Chalapalli, consultant oncologist in Bristol, specialising in the treatment of urological cancers with radiotherapy and chemotherapy.
My name is Barry and I'm a bladder cancer patient.
My name is Nigel and I'm a bladder cancer patient.
And my name's Janet and I'm also a bladder cancer patient.
Okay, thank you. So I'd like to start with John, if I may, and just ask, could you give us some further details about muscle invasive bladder cancer, please?
Sure. So the bladder, as your audience will be aware, is the organ that's responsible for storing urine, and then all humans have the ability to control when they're going to empty their bladder. The bladder has several layers, and bladder cancers can be either on the surface of the bladder lining, but once they actually grow into the muscle layer, which is the layer below the surface, then those bladder cancers behave in a slightly more aggressive way, and for those bladder cancers, treatment is recommended, and we're going to talk more about that today.
So we have a bit of a story to tell, and we're going to look at what happens to a patient who receives a diagnosis for the muscle invasive bladder cancer. So we're going to look at sort of the next steps. So I'd like to go, John, if you could.
Sure. Well, conventionally, patients are diagnosed after they've had a procedure called a transurethral resection of the bladder. And when they've had that procedure and the tissue is looked at, then when the pathologist looks at the levels of the bladder lining that are involved with cancer, they're able to give a muscle invasive bladder cancer diagnosis. For those patients, they are all discussed at what we call a multidisciplinary team meeting, and that's a meeting where all the specialists are present. So that's the surgeons, the oncologists, the radiologists, okay? In addition to members of the nursing team and the allied health professionals involved in looking after patients with bladder cancer. At that meeting, we talk about all the treatment options that might be suitable for patients. So that includes non-surgical options and surgical options. And often with muscle invasive bladder cancer, we try to offer those patients the option of neoadjuvant chemotherapy as well. And we therefore make sure that all patients who are diagnosed with a muscle invasive bladder cancer go on to see both an oncologist and a surgical doctor as part of their ongoing treatment management.
Okay, thank you. And you mentioned about chemotherapy, so I don't know if you can, as the oncologist, if you could add some more information.
Sure. As John alluded to, once the patient is discussed in the multidisciplinary team meeting, they are sent an appointment to come and see the oncologists and the surgeons in a joint clinic appointment, where the discussion is between organ sparing approach, which involves radiotherapy, versus surgical approach in terms of treating the bladder cancer. Prior to the radical options of treatment, there is a role for neoadjuvant chemotherapy, which is basically giving chemotherapy prior to the patients having surgery or radiotherapy. The benefit of the neoadjuvant chemotherapy is that it helps improve survival, that is how long a patient lives, and hence that would be the recommended option. Bearing in mind, this option is not for all the patients. It essentially depends on the fitness of the patient and also their renal function. For the patient to be able to be eligible or receive neoadjuvant chemotherapy, their renal function has to be optimal and they have to be fit enough to receive the treatment. And once the patient completes the neoadjuvant chemotherapy, then they have the option of either sparing their bladder, which is through radiotherapy in combination with chemotherapy, or with removal of the bladder with a cystectomy.
So we're now going to turn to one of the patients, Nigel, because I understand that you did have the chemotherapy treatment. But I just wondered, when you first had that diagnosis, how did you feel? What was your experience around when you had that?
The usual thing, shock. It can't be me. and the surgeons we talk to say the first question the patient always asks to them is, what would you do? They can't answer, it's up to you. It's how do you trust your surgeon, do you trust your oncologist? You go by what they tell you, what the advice, take the advice, and then you have to make up your own mind. I had diagnosed as a very aggressive, invasive bladder cancer, and I was told really I should have a course of chemo, which I went ahead and did, which is a course of 3 twice weekly, and then I had a month's rest. During that time period I had a CT scan, and I was told luckily that I was cancer free. Jubilation. I then had a discussion with my oncologist and my surgeon, both of them I liked and trusted, and their advice was that I still went ahead and had a full cystectomy and prostate removal. That was my choice.
So just to step back to the chemo, like how was your experience of chemotherapy? How did it make you feel, the side effects?
You hear all the rumours, this is going to happen, you're going to be sick, hair's going to fall out, etc., etc. They give you medication to reduce the sickness. I think that depends on, everybody is different. My case, I didn't feel sick. The medication worked. I had my treatment at home, luckily, which was one session was 9.5 hours on a Monday, and then 4.5 sessions on a Friday, pumped through the veins. They warned me as they were doing it that this might happen, that might happen. The hair might fall out, it will fall out, etc., etc. So I think a lot of it depends on what type of chemo you're having, because there's lots of types, but there's also, it's how it affects different people. So, no fear, and it worked. All clear.
So Nigel talked around side effects of chemotherapy. Are there any, and I know it's quite individual, so are there any other side effects that somebody could expect?
Yes, I mean, I think Nigel made an important point in that, all the side effects which could potentially happen are not necessarily that they will definitely happen. It is all an individual basis on how the patient copes with the treatment. I mean, one thing I would also advise the patient mainly is the risk of lowering of the body immunity, which happens usually around the second week after the treatment. And during that time, the white cell, the cells which fight infection in the body, the count goes low, and the patients are more prone for infections. So I always advise the patients that if they are feeling unwell or having a temperature during that time, they need to immediately call the hospital to have a blood test and make sure that the blood counts are checked, and maybe if required have antibiotics. So, and it is not necessary that they will always require antibiotics with every cycle, but there is the potential that the blood counts go low with each cycle, and that's what they should be mindful of.
And then my understanding after chemotherapy is it is it a choice between radiotherapy and surgery? Is that?
So yes, I mean I think the neoadjuvant chemotherapy is done usually anywhere between 3 to 4 cycles, and after the 3 cycles, usually we arrange for a scan to ensure that there is no spread to other parts of the body, and we also try and do a cystoscopy, which is to have a look inside the bladder to see if there is a good shrinkage of the tumor within the bladder, and if there is no distant spread, and if the tumor has shrunk considerably with the chemotherapy, then the patient has the choice of either proceeding with radiotherapy, along with chemotherapy, what we call concurrent chemoradiotherapy, or have the option of surgery. If the cystoscopy shows that the bladder tumor hasn't shrunk enough, or if the bulk of the disease is such that there hasn't been a difference with the chemotherapy, then the patient would be better off with going down the route of surgery.
With the radiotherapy, just to talk about that a little bit, over what sort of time period is that? What can somebody expect when they have radiotherapy? So the radiotherapy is also a curative option after neoadjuvant chemotherapy. Usually it is done over a period of 4 to 6 weeks, done in the oncology center, and it is done as an outpatient. The patient comes in every day for the treatment, about 5-10 minutes each day, but there is a lot of emphasis on maintaining the position of the bladder and the rectum, so that we ensure that we are treating the
the tumor each day and not missing the tumor. And we also use what we call IGRT, or image guided radiotherapy, where we monitor the positioning of the bladders to ensure that we are treating the bladder completely and not missing any part of the tumor. And in patients who are very fit and the renal function permits, we also consider giving chemotherapy along with the radiotherapy, and usually that is done in the first week of the radiotherapy and in the fourth week of the radiotherapy. So, and the patient is monitored regularly with regular blood tests, and also monitored with the radiographers for a regular review to manage the side effects of the radiotherapy. And once they complete the treatment, what is important for the patients to be aware is that they need regular camera tests or the cystoscopies to follow up what the position is within the bladder, and also regular scans to ensure that there is no spread.